Hello, my name is Rana Abdalrahman, and today I will be presenting on psychiatric outcome prevalence in young adult stroke survivors. So to begin with, what is a stroke? So a stroke occurs when blood flow to the brain is obstructed, which is what's called an ischemic stroke, or a blood vessel in the brain ruptures, which is what's called a hemorrhagic stroke, leading to brain cell death. This can result in permanent disability, such as being unable to walk or having weakness in the arms. The effects of stroke can further manifest into cognitive and psychiatric effects, such as mood disorders, which I will be discussing in detail today. It can also manifest through finances, with the individual being unable to work and losing employment. And lastly, it can result in significant social effects by altering a person's ability to return to their pre-stroke routines. As a cause of this, mood disorders are very prevalent, and up to one-third of stroke survivors are affected by post-stroke depression and post-stroke anxiety in their first year. Young adults are especially vulnerable to mood disorders because of the specific issues they disproportionately face, such as loss of employment, childcare, and a reduced life satisfaction. In fact, qualitative studies suggest young adults prioritize life participation and return to work and social roles as their main rehab goals. However, although this issue is quite relevant, current literature on the prevalence of post-stroke depression and anxiety in young adults is limited, and this is because there's no uniform definition of stroke in young adults, whether that be the age range, which in our case we define as 18 to 55 years old, or the type of stroke. And additionally, prior meta-analyses excluded age group restricted studies. So what were our study objectives? So our first objective was to conduct a systematic review and meta-analysis of the literature on observational studies that evaluated symptoms of post-stroke depression, post-stroke anxiety, and comorbid post-stroke depression and anxiety in young adults. Our second objective was to report the prevalence of these symptoms and describe the different methods of evaluation for symptoms of post-stroke depression and anxiety. How did we go about doing this? So by following the PRISMA guidelines, which are the preferred reporting guidelines for systematic reviews, we searched various databases for studies falling within the inclusion criteria, which I will be describing, from inception until June 23rd, 2023. We then followed that with a random effects meta-analysis of proportions to determine pooled estimates of the prevalence of mood disorders, and we followed that with I-squared tests to assess for heterogeneity. In terms of inclusion criteria, we included all studies that reported on symptom prevalence of depression and anxiety in young adults. For types of stroke, we included transient ischemic attacks, which are known as mini strokes, with symptoms that resolve in a brief period of time. Infarcts, which are the occlusions in blood vessels of the brain. Intracranial hemorrhage, which is a bursting of blood vessels in the brain. Or subarachnoid hemorrhages, which is a pooling of blood between the skull and the brain. We included all participants aged 18 to 55 years old, and all our studies were published in English. We excluded all studies that were limited to specific sex or stroke severity, and we excluded any studies that did not use a validated screening tool or structured interview based on diagnostic criteria for post-stroke depression and anxiety. This is a Prisma flow diagram to visualize our study selection process. So we started with 1,872 studies, which were further narrowed down to 160 by screening. And then we included 20 studies in our qualitative synthesis, which was our systematic review, and 16 in our quantitative synthesis, which was our meta-analysis. In terms of the prevalence we found a pooled post-stroke depression symptom prevalence of 30.94% with an I-squared value of 96, which is quite high. We found a pooled post-stroke anxiety symptom prevalence rate of 38.91% with an I-squared value of 90, which is once again quite high. And for the pooled comorbid post-stroke depression and anxiety symptom prevalence, we found a rate of 25.45% with an I-squared value of 93%, which is once again quite high. So what did we find overall? So overall, the pooled symptom prevalence rates we identified corresponded to previous literature, with around one-third of survivors being affected by mood disorders. However, our study found high heterogeneity in studies investigating the prevalence of symptoms of post-stroke depression and anxiety in young adults, emphasizing the importance of standardized approaches in future research. This high heterogeneity value is because the included studies differed in terms of their inclusion criteria, diagnosis methods, and evaluation timelines. Thus, it can be seen that there is no standard method to screening and diagnosing these individuals, which indicates a need for further research into the best screening and diagnosing tools in order to support this vulnerable population. Additionally, we identified a lack of longitudinal studies tracking psychiatric and functional outcomes over time, which would be useful for investigating predictors of these mood disorders and providing further support to these individuals. These are a list of my references. Thank you for your time.